Welcome to another episode of Black Scholars Speak as we laugh, inspire, uplift, and challenge the status quo. This is Black Scholars Speak. Hi, everyone, and welcome back to another episode of Black Scholars Speak. I am your host, Janelle Gore, and this is where we are connecting research, culture, and community. Today's episode features an incredible scholar whose work is transforming the way we understand dementia caregiving in Black families. So today we're joined with Dr. Karen Moss. And so welcome and thank you for being here.
Thank you. Thank you so much for having me.
Yes, thank you. So today in this conversation, we're going to explore her scholarly journal as a Black nurse scientist and lived experiences that have shaped her work and her innovative peer support program, Pair to Care, designed with and for Black family caregivers. So we'll dive into the realities of caregiving, the systemic barriers of that Black families face in dementia care, and how culturally responsive support can change the outcomes and lives of these families. So I always, you know what the drill is. I always start out with a formal introduction because I do think it is really important, especially if we don't get to everything in the episode, that you have something if you're interested in to follow up on. So Dr. Karen Moss is a registered nurse and nurse scientist who is an associate professor of nursing in the College of Nursing at the Ohio State University. They're very, y'all love the.
Yes. It's the State University.
She is a distinguished fellow in the National Academy of Practice Nursing Academy and a fellow of the Gerontological Society of America. Dr. Moss's work focuses on improving, advancing care planning, and pain outcomes through palliative and end-of-life care for older adults living with dementia and their family caregivers. She examines multiple perspectives on factors that influence pain and end-of-life decision-making processes for Black older adults living with dementia and their family caregivers. Dr. Moss's research is also focused on developing and testing Pair to Care, a peer support program created with and for family caregivers of Black people living with dementia. Through her work, Dr. Moss and her team are actively working to improve the quality of life of Black family caregivers and their older adults living with dementia. Awesome.
Thank you.
And so as we start this episode, do you mind just talking about your journey into nursing and becoming a nurse scientist? We talked to Dr. Gibson yesterday as part of the aging series that we're doing. And so just, what's your journey? Because everybody has a different one.
That's right. And we have to own our stories, right? So thanks again for inviting me to be a part of this. I am so excited for you and this work. So my journey in nursing started actually when my maternal grandmother was diagnosed with colon cancer. And she spent several months in the hospital, ended up having to have a colostomy done. So she had the bag and, and would go to the hospital just about every day with my mom. And just watching the nurses and what they did, I was intrigued. I'm like, I want to know, what are they doing behind that curtain? So I am from the Bahamas, born and raised.
Okay, I didn't know that.
Yeah. So born and raised there. And so we used to be British, right, under the British rule. And so we have in our public hospital system, it's set up with wards. And so you have curtains. And I remember, just watching what was going on with the other patients while I was visiting with my mom, my grandmother, just being kind of nosy. And I was like, I want to do what this nurse is. And I later found out, as an aside, that my mom, this was her dream herself. She wanted to become a nurse. that never happened because of family circumstances.
Right.
But I only knew that after I had shared that this was my goal. And of course, she and my family supported me in that very graciously. So I started my career in the Bahamas and then transitioned to with an associate's degree and then transitioned to Orlando, Florida, where I got my bachelor's in nursing. And then went to the University of Virginia for both the master's and PhD in nursing and have never looked back. Have never looked back. I also did a postdoctoral fellowship at Case Western in the School of Nursing there, and then transitioned to a faculty position at Ohio State.
And so what made you do not like a, what do you call it, like the doctorate?
The DNP?
The DNP,
Yeah.
do the PhD.
Yeah, that's a great question. So during the BSN to PhD, which is like a bridge program, you come with your bachelor's, you leave with your PhD. I had the option of doing the master's, right, in any degree that I wanted. I chose to do the clinical nurse leader track simply because it was the shortest, it had less clinical components, and I did not, working as a nurse practitioner was not part of my plan. And so my goal was to research and teaching.
Okay.
And so that's why it was like, okay, get me to the PhD quickest so I can get out there and do the work.
And so what interested you in the PhD?
Yeah, interestingly enough, to be completely honest, so I was a critical care nurse for most of my clinical career. Loved the adult ICU, had a love for end of life and decision making, just always fascinated by death and dying. I'll talk a little bit about that. But I wanted to teach. I wanted to teach. That was the goal. And I said that if I do this, I need to get a terminal degree because I was also at the phase of life where we were starting to grow our family, my husband and I, and, if I'm going to do this, I need to do this and be done. Like, I don't want to stop. And I did that, thankfully, and no more school. And so after, it was after, so the naivety of this for me, was after, getting into it, writing the application, trying to figure out, do I want to set ventilators because I loved ICU, the critical care setting, but I also, because of this fascination with death and dying, I'm like, oh, this would give me an opportunity to dive deeper. And also along with that, realize the disparity and disparities faced with Black individuals, even just around death and dying and that process and preparation, the lack thereof, having a document written, which is the gold standard for hospital system.
Right.
Black people, we're more likely to have the conversation, but it doesn't always translate to a signed document. So that contracting, if you will, with hospital systems or the like, is less likely to happen. And that poses a problem, right? And so that, I was excited that I can get to dive deeper into this aspect of the research aspect of death and dying, and have never looked back.
So the first thing I think when I'm like, oh, what do I want to do for my career is not death and dying.
No one does. No one does.
So wait, how did you get into death and dying?
So when I look back, I think it was probably my when I was in nursing school the first time around, you go to clinicals and there's always a debrief post conference. And what we would do so when you get your assignments in the hospital, you would usually get a patient who was very stable, often what we call walkie-talkie, self-sufficient, that sort of thing, and somebody who was more critically ill, who needed more care. And so even on the medical floor or something like that, that would be the scenario. Oftentimes when we got to post-conference, I was sharing with my colleagues and my professor, one of my patients passed away. And so I got the nickname as the death nurse. So, and I was totally okay with it. Like even being there, some of the patients we coded, some we didn't, because of what was going on with them and what the plan was for them. So, but either way, I got to be a part of that. And it was something really, and I think it has to do with my spirituality, my faith, there was this deep connection to, what happens to one, what happens to the body, what happens to the soul, and all of this notion around death and dying that has always fascinated me in some ways. I don't have a lot of personal experience with death and dying, and maybe that is protective, but I have a lot of professional experience, right, with it now, and even from my student days. But I think it's the notion of what happens in and around death, that period just before, the just after, things that the families go through, how they prepare. I've always had this desire of how we can make it, how can we make it better for these, not just for the person who's passing away, but for the families who are left behind.
Right.
Yeah.
No, man, I'm gonna try not to cry in this. But I mean, because a lot of like what you're saying, it resonates with me, because like, so I'm on the side of, I guess, like the family who's like gone through it, right? So my mom passed away in
March of this year. Oh my goodness.
So she had stage 4 cancer for about 4 or 5 years. Thank you. But our family never wanted to talk about like the end.
Yeah.
Right? We were always just kind of like
the here and now.
Right. Like, oh, it's going to get better. Or like we just kind of think about it. So literally, when you talk about contracting, the day that she passed, my dad was like, oh, we got to do the will. We got to do like this stuff. And it's like, you've got all of that going. So with families, as they're trying to navigate this, what have you learned from your work on how to like prepare for those moments?
Yeah. So thank you for sharing that about your mom. I did not know. I am so sorry for your loss.
Thank you.
Death is never easy. So one of the things that helps, so you're right, no one wants to talk about death.
Yeah.
And no one wants to do it, especially when we're in crisis. And so when I was first thinking about the work that I would get to do around end of life and end of life decision making and my connection to the intensive care unit, I wanted to help. The first drive was to help these families who are facing these crisis circumstances to plan better. And then I quickly realized it was too late in the game to try to make this impact, because it's already at the moment where stress is high. It's hard to make decisions, and this is what I saw. This was the prompt.
Right.
And so I had to step back and I said, okay, well, if the ICU situations are too late, where can we capture people's attention, or focus to be able to pay more attention to this preparation prior to, and it's in the community. It's in the community. I look over at the table over there and I think about the kitchen table, having these conversations when there's no pressure, no one's sick, no one's facing death. We're just having a conversation about, if something happens to me, I have 2 teenagers, I have a husband, I have both my parents alive, who will be my decision maker? And so for somebody like me, sometimes a parent might feel like, oh yeah, I have a say, but legally my husband is the decision maker.
Right.
When my husband's no longer here, how do these adult children or semi-adult children, our daughter is 18, she can make decisions. How do they navigate that? And how do I, as I approach death, try to, as hard as it is to broach that conversation with them while I'm alive and well, these possibilities, right? How do I broach that during this time when things are okay, so that when things are not okay, that they'll have a blueprint.
Right.
Yeah. So I think having these conversations in the community, making them part of everyday conversations, low stakes, using, like when I go into the community and I have events at health fairs, there's always 5 wishes, which is a very basic, and I'm not putting in a commercial. I don't have any state. No. But it's just a very basic document that you can, it helps one think about what their wishes are, what they want done, not want done. The first step, who's going to be that decision maker? And does that person know what you want? Whether or not you want to be kept alive on a ventilator, you want CPR done if your heart stops, even the after death stuff, which is important too, especially in the Black community. And that came out in my research. So when we're, and I get excited about this, you gotta. This notion of when you, like I saw in my initial study, my dissertation work, when we even say the term end of life, oftentimes in the Black community, our minds go to the after death. So you talk about, okay, we're going to talk about preparing for end of life. And then people start talking about the funeral plans and the burial and burial insurance. But a healthcare provider who's
Do
asking,
they even talk about like faith too as well? Like,
oh yeah, faith is all the way integrated, right? Because how that memorial or funeral service is going to look is totally centered around whatever their faith looks like or doesn't, right? So, even thinking about that, and the flip side of that is when a healthcare provider typically asks about end of life plans, they want to know, do you want to be on a ventilator? Do you want CPR done? So it's very different. It's something has to happen.
Communication
Exactly.
isn't connected.
Exactly. And that's what we found that came out.
And expectation differ because it's not the same.
Exactly.
It says, I remember when we were at the hospital, the palliative care nurse she came in and she was like, all right, so these are the things that we're thinking about. We're thinking about like a transition hospital, basically, where like she could stay for like longer because the hospital can only keep you for so long. And we were like, wait, what? Wait, so you're saying she's dying? And she was like, no, we're just saying we gotta like prepare for some of those things. But it's tough when like you don't, like you say, like you don't have those conversations.
Yeah.
And then I think it's interesting too within the Black community, the faith component. Because I noticed like for our family, we turned immediately to like, not that we didn't know that she was going to heaven. But it was like, we got to make sure she's spiritually prepared and ready to go. So that was like more of our like forefront. But then afterwards, we're over here depending on dreams. Like in terms of, wait, what is Satanic tell us in this dream? Because we didn't talk about it.
I don't know if I've heard the dream now before. That's a new one. But whatever it is, and that happens. That exact thing happens. Families are struggling to figure out, well, one time, a grandkid will pop up and say, well, grandma told me that she don't want to be kept alive. She doesn't want to be a vegetable, so these little things that people can, and years ago when so died, grandma said,
Right.
And so that's what you have to hang your hat on, right? In that moment, in those moments of crisis, to hope that you have some sort of reassurance that you're doing what that person wants. But who knows, right? And then not only, here's the other piece that complicates it a little bit, but not in such a bad way. We don't know necessarily. So this notion of things change. So how I felt as a mom of young dependent children, if something were to happen to me, looks probably a little bit different, right? As a mom of parents of, if they were adults, like full-grown, it's different, right? And how you plan and who decides and, all of that, it looks different.
It does.
Yeah.
And it even looks different, I know, for families who are affected by dementia.
Oh.
Because when you're talking about preparing and like the end of life care, you could be doing that for like, what, 5, 6, 7 years?
10.
Right.
Yeah.
And so what have you seen there in terms of like how families are addressing end of life care in those instances where it's not as like immediate necessarily?
So one of the, unfortunate as dementia is, right? One of the fortunate things, the good things that we see have come out of it, and this was proven in my dissertation work as well, where we saw high percentages of people who planned or identified a person because of the dementia diagnosis. So it almost was a prompt for families to perk up and be like, and maybe it's the healthcare provider saying, this person with this diagnosis, even though they have maybe the decision-making capacity at the moment, but in the future they won't because of the progression of the disease, or they don't have it now and y'all need to get your act together, And so I think that has been a prompt, We saw that in our dissertation among Black family caregivers in particular. And so I think dementia helps with that. But at the same time, if families wrestle, right, and don't know or avoid making the decision, then you still have the same circumstances.
Right. Or you're navigating all of the different resources that are out there.
Yeah.
And then, like, at least for me, I know. So, like, with ADHD, if I get too overwhelmed, I shut down. So,
Yeah.
but I feel like that happens with like resource and like information overload. Like a lot of families that I've encountered just they kind of shut down and then nothing gets done. And so I feel like and you can talk a little bit more about Pair to Care.
Yeah.
How are you all kind of addressing like resources and empowering caregivers and really building this like community where you're not walking this journey alone?
Yeah. So Peer to Care is a peer support program that was designed with and for Black caregivers or people living with dementia. Actually, it was co-designed with them. So we had a study before the initial testing of Peer to Care where we found out from current and former caregivers, and former caregivers are those who are experienced. Their loved one who lived with dementia in the past is no longer here. They passed away. And so we're leveraging this wealth of knowledge and experience that these individuals have to be of support to somebody who's currently caregiving for someone living with dementia. And it's a 6-month virtual program. We provide training for our mentors before we send them off. We have a wonderful, really nuanced hearing process that we go through and how we figure out who might be a good match with who that has like a
matchmaking.
Yes. One of my colleagues described it as in the future like a Tinder for.
Well, so that's literally in my head. I was like, I could see this being an app.
Hey, we can do great things we're going to be doing great things with Peer to Care.
Yeah.
I'm going to say that. And so figuring out how to, we use some quantitative metrics and then we figured out with some qualitative pieces and decide who we should bring together. And it's been amazing. We conducted the initial testing, the feasibility, just to know whether or not people would come and whether or not they would stay. It's 6 months. You're asking somebody to connect for 6 months with a stranger. We didn't know how this would work. But I will tell you, we were blown away. We had... it took us 10 weeks to enroll all of our participants, to train our mentors, and to pair everyone. 10 weeks. And we had 15 dyads just in this initial testing. No one left the study.
Wow.
No one left. Unheard of.
That is unheard of.
We did have a couple, we did have a care recipient that passed away, and we know that with dementia, that can happen, unfortunately. And then we had a mentor who became ill and wasn't able to continue just at the very end.
Yeah.
But we also, it's just feasibility. So we know people came, they stayed.
Right.
So it's feasible, it's acceptable. And we're now, we have applied for additional funding from the National Institute on Aging, the NIA, to conduct efficacy testing.
Oh, that's good.
Yeah. So we're trying to hold on to all of the hope that would happen because of what we saw in the feasibility trial. And I will tell you, Janelle, 2 years after, so this summer made 2 years since we were recruiting and launching the study, ended recruitment. We're still getting calls from people in the community trying to get into the study. Yes. The other cool piece of this, so yes, the focus was on the caregiver, the person that's currently caregiving. But we were talking to the mentors as the program was progressing, and we were hearing these powerful stories from them about what this relationship was doing for them. Like they weren't even, like we weren't watching the mentors so much, right? But we heard that, for example, for the first time in my life, after caring for my husband all those years ago, I get to say that the care that I gave him was good. So just imagine, as a caregiver, you're carrying that burden of, did I do the right thing? Did I make the right decision? And this could be anywhere from diagnosis to death, and even after death, right? The struggle of did I do it right? Did I get it right? But then you get to talk to this person who's currently going through, and you get to impart your life experience. You're not an expert of anything. They're not expected to be healthcare experts. They are experts of their own experience. And they just share that. And that mentee, the caregiver, is able to do whatever they want with that. They can take and, they can access resources based on what the mentor said they accessed and was helpful for them, or they can choose not to, right? But it's someone that they can connect with. Our participants in our previous study told us that they wanted, because as a nurse, I can share this with you, future scientists, I went in thinking, we would end up with a nurse-led intervention that would be of support to caregivers, particularly at the end of life, advanced care planning. But what we learned from these individuals was that they wanted more. These caregivers said, yes, planning for the end of life is important, and that is included in shared care.
Yeah.
We didn't lose that.
Yeah.
But they wanted more. They wanted that overall support, and they wanted it to be led by somebody who
knows.
Yes.
Exactly. Because then you can have those candid conversations.
Yes. They also wanted, part of that is they wanted somebody who would be non-judgmental. They wanted to be able to share openly that I love my fill in the blank person that I'm caring for dearly, but this is hard. Actually, it sucks, and I'm tired.
Yes.
And I don't want to do this anymore without somebody pointing their fingers and saying, how dare you?
Right.
That's your mom. How dare you? And so they also wanted to be connected with somebody who got them culturally. They wanted to not have to explain the intricacies of approaching the healthcare system, navigating the healthcare system as a Black caregiver. These are their words, not mine, right? And they wanted to do it in a way that was flexible. And so this is why we built, co-designed Care to Care in this way to meet their needs. And by golly, it worked. And so I say that to you as a future scientist that, when we work with human beings, right, whether it's in the community, whether it's in healthcare systems, wherever, one of the things that's the onus upon us as researchers is that we have to ask relevant questions. Number one, we have to ask relevant questions. We can be guided by the literature, as we should. Ask relevant questions of the people that we intend to help. Like, don't dream up stuff in your head and expect to put it together and say, here you go. And it's supposed to work.
And
ask the relevant questions of the people you intend to help. Listen. That's a key component. Like, you have to listen, right? And then you give them what they ask for. Like, it seems so basic, but I think as scientists, we tend to miss that, right?
Well, because there's a lack of connection a lot of the times with the community. I see so much where we have all of these researchers, some working with not their racial groups, who go in and say, well, like you said, the literature says this, it says this is evidence-based. But for who? And how is it whenever we go and we impart these interventions, did we not ask them what the barrier before that is?
Yeah. Is the intervention meeting the need that was identified?
Yes. Did you even ask what the need is? So, because when you were talking, and you said about, one of the participants, their recipient passed away. Something that popped into my head and thinking about need, right? We don't ever ask what the caregivers after their persons pass away, what then they need.
Great. Yeah. So that is something that has been, it's now a cornerstone of my work. So this actually started, so with my dissertation, I only interviewed caregivers. I only collected data, 65 of them. It was all across the state that I was in, collecting these data from caregivers. And what ended up happening was, so I was in the community, volunteering with the Alzheimer's Association, volunteering with hospice. And what I found was, it was interesting that oftentimes, I meet people in the community. They knew I was a PhD student and doing this work, and they're like, "Oh, yeah, I'm caregiving for my XYZ, let's stay in touch, reach out to me when you're ready." And you're in the community, you're meeting these people, you get to know them all the time. And so when it was actually time for me to conduct this work, and I reconnected with some of these individuals, and they shared things like, "Oh, mom passed away, a couple months ago," or something like that. And it was shocking to me. It wasn't a large percentage, but just like in qualitative work you do, even if it's just one individual, sometimes if you follow that train, it can lead to something amazing, right? And so I thought, the next study that I conduct, or in my future, I want to be able to include these former caregivers, because they have such a wealth of knowledge and experience that really and truly, like, what do they do with that? They don't get a prize for it. That's certainly not the case. They don't get any award. And they kind of bottle that up, maybe until like the next, as one of my community advisory boards described it, the next tour of duty. So the next family member faces this disease, and then you have to provide caregiving. And so I thought, we need to leverage these individuals, because actually in the fam care study that led to peer-to-care, some of our participants, the former caregivers that we interviewed, they said, "Oh, yes, we want to continue to be in research studies." And I was like, that's fine and good, but all the caregiving research wants people who are currently caregiving, but who, by the way, they don't have a lot of time. They don't have a lot of time to give. And so I thought, I'm going to be able to use these individuals. And by golly, they are, we have, and I'll say this and I'll pause, we have folks who were in our peer-to-care study who were mentees, meaning they were currently caregiving for someone living with dementia, who have since lost their loved one. And they're raising their hands now to say, "I want to be a mentor in peer-to-care."
And you see this kind of across different types of caregivers, across chronic health conditions. Because like I think about my dad. He's like, I finally am at a space where I want to give back. So he's looking at what is it called? I think so, like the Stewards Ministry. Have you heard? It's like it's basically where previous caregivers can help to support others who are kind of going through stuff. So kind of similar, but it's more like faith-based rooted. Stephen's ministry.
Yep.
Yes.
Okay.
And so he was like, like I feel like, I'm right. And then it's interesting because now he is getting more involved in like the church that like him and my mom went to. He wants to, go back to get his divinity and stuff.
Wow.
So you're right, you see this shift. But oftentimes, even those caregivers need help with the shift.
Yes. And what we tend to do as a society, really, after you're done with caregiving, so there's supports out there, insufficient though it is, there's supports out there for caregivers. But when you are done with caregiving, meaning when your loved one passes away, it stops. That label is gone. Things you would have qualified for, that's gone. And society,
your identity changes in a way.
It changes. And what we say as a society, even with that changed identity, go back to being who you were before. Get back to work. Now you have all this time. You should be, just go back and just, pick up where you left off. Caregivers have to leave their jobs oftentimes. They have to, or take reduction. So if you think about it.
Right. So go back to what?
Exactly.
Because I haven't been working, like.
Exactly. The financial impact, right? By even taking a step back, the overall career impact, right? So how you have to slow down or stop progressing in your career,
So sorry to interrupt. How could you see this within policy? And addressing, right? So, because where my head is going is addressing healthcare costs. So if we can be able to help previous caregivers transition, and then just with peer-to-care, be paired with someone who's going through it. I wonder if even maybe this is the next iteration for a study, but if it does reduce like the amount of hospitalizations, now you've got a more confident caregiver. So then the quality of care is improving.
Yeah.
And to me, that's also addressing like the quote unquote burden that's placed on the healthcare system.
Yeah. So I think you hit it right on the head. The impacts of peer to care is far reaching, right? So even though the care recipient, the person living with dementia, is not a part of it, they're indirectly impacted. They're indirectly impacted because if that caregiver is able to stay well, that's the goal. Stay well, not just physically, also mentally. Health-wise, they do a better job for caregiving for their loved one. They show up better because it's not just, caregivers are really just caregiving for someone living with dementia. Oftentimes they're raising kids, sandwich generation. They're caring for the other parent, right? So it's not just the one thing, right? And so this ability to, and what they're doing, what caregivers are doing is really helping the healthcare system, right? So when caregivers leave the work system, their work environment to care for their loved one, to maybe try to keep them out of a nursing home, right? That frees up the bed for somebody who needs to be there. If they're able to manage their loved one and use adult daycare services instead, and that gives them that reassurance that I'm doing what I feel I need to do for my loved one. But it comes at a cost.
Right.
And by helping healthcare systems, in doing so, we need to be able to do a better job of, I don't want to use the word reward, but to be able to thank them in a better way. So recognizing what they do, compensating them for what they do. So from a health policy perspective, whether it's at the state level, at community-based organizations, within cities, area agencies on aging, and providing resources for caregivers in this way, especially if they have to reduce their time at work or leave work completely. State level, absolutely at the federal level, to be able to recognize how important it is, because you're right, it's not just dementia.
Yeah.
There's other types of caregiving that can benefit from peer to care as well.
Yes, and before we kind of start to transition to end, I want to make sure I don't miss this piece with folks, that what's unique about peer to care is the fact that it's Black caregivers supporting Black caregivers.
Yeah.
Because there are systemic issues that are unique to our experiences and what we face.
Absolutely. And that is well documented. Well documented. No one's making this stuff up. The gap, this disparity is there and it's real. And this is how we embarked upon this work. This is the way science is supposed to be conducted. And that's the reason why we focus on this population. We have always had the goal with peer to care to one day open peer to care up to other racial and ethnic groups, because there is a need in other racial and ethnic groups. And we recognize that even prior to getting started. But remember, when I talked about how we designed peer to care, even within the Black community, we decided that family care study, we recruited current and former caregivers who were lower socioeconomic status. And our goal was so that those individuals who are in that even more so marginalized subset, when the intervention is designed, it will meet their needs as well. And that's like all within the Black community. And so now we have this program that is hopefully meeting the needs of people who are in the lower who are in lower socioeconomic statuses, and then also people who are in upper, and everything in between. And so the next step then will be, how can we open peer to care to other racial and ethnic groups? All of those places and spaces that you think of where caregivers are, is just everywhere, right? And helping to be able to meet their needs there.
In a culturally relevant way.
Exactly. Because participants, constituents in peer to care can get to decide, what is important to me? What do I prefer to be paired on? Do I want to be paired with somebody who maybe also has grandkids? So we can talk about...
Man, oh my gosh. Okay. Man, there's so many questions. Oh my gosh, that I have. So many ideas that I have. Some of them I'm like, I don't even know if I want to share them on the podcast. Yeah, because I'm like, we need to talk first.
Yeah. Yeah.
But as we conclude and we close this episode, I think, and I know I've gotten, just emotional. I also too am tied deeply within the work that I do. Yeah. So I am very empathetic in everything that I do. But as you are working in this death and dying space and with caregivers, and it is a heavy topic, even like dementia and stuff like that. How do you protect and care for yourself? And then what advice do you give to other researchers as we are working with these really tough topics?
Yeah.
How we care for ourselves in the midst of this? Because
Yeah.
I think we forget we're a part of the community too.
Yeah. And it can be a plus and it can be a minus, right? To be so connected to the group that we're working with. And I think what excites me, what keeps me grounded, what energizes me around this work is just the connection, the close connection that I get to have with the community. I consider it an honor, an absolute honor to be connected with folks in this really just empowering way. So the connection that I have to my community advisory board, they sustain me in so many ways. It's unreal. It's unreal. We talk about different things and how, to navigate and how peer to care should be maneuvered. And, it's support. So I get support from them, right, in this process. Like they're there to help me with building this program. But me, Dr. Karen Moss, the researcher, I am supported by them. And so being close to the community, being able to see the impact in the community, being applauded by members of the community for doing this work. Thank you so much for doing this. I am so glad. They will tell us at the end of the interviews, I am so glad you're asking these questions. I'm so glad, even before the intervention, I am so glad you're talking about this because no one asked me about this. As a person who caregived in the past, nobody asked me about what it was. So thank you. And so that is what...
To feel seen.
Exactly. To be seen, to feel heard, and that energizes me. And I will also say when I travel, so I have a whole cadre of self-care practices that I do. I love to cross stitch. I love to cross stitch. I learned from my 5th grade teacher and I still do it today. And that I do yoga almost every morning, just a little short one to get me set for my day.
Yeah.
I do like to work out. Sometimes it's hard, especially when you have a brand new. But, these are some of the things I really, really enjoy. I'm just kicking back with my family. I'm a mom of 2 teenagers right now, and I'm loving this phase of life. It's like parenting these kind of mini adults.
I know.
And, you get to have adult-ish conversations with them, and they're wonderful kids. And so my husband, who supports me, ensures that I make sure that I'm taking the time to rest and disconnect. I am blessed to have my parents with me still. They're both in their 80s.
Oh.
So I really feel so blessed.
Yes.
So blessed. And so all of that keeps me going. But it's what I'm able to see that this work, in this case, this program like Peer to Care is doing in the community, that keeps me going.
I think it's when you put authenticity in, you get authenticity out. Well, this has been such an awesome episode. I mean, I'm learning stuff I didn't know first, because I was talking to somebody who was like, yeah, actually, I don't know a lot about Dr. Moss. And so even like our conversation, a lot more. No, and so that I think that's why I was so like real authentic responses where you were getting real questions. I went totally off script.
I love it.
But thank you all for joining us for this powerful conversation with Dr. Karen Moss. Her work honestly reminds us of how essential it is to center Black families, Black caregivers, Black experiences in dementia care and end-of-life decision-making. From her creation of Peer to Care, Dr. Moss is not only advancing science, she's building community and transforming lives. So if today's episode resonated with you, be sure to share it with someone who can benefit from this knowledge. And as always, continue to uplift and support Black scholars doing this critical work. Until next time, keep learning, keep growing, keep speaking your truth. And thank you so much again, Dr. Moss, for being here.
Thank you. I have had a blast.